Chris and Edgar, go ahead.
Wonderful. Thanks so much. Thanks everybody for joining for this month's PTS-AAST virtual case conference. It's a pleasure to be here with you today. Today we have two different cases that will be presented by Dr. Margot Debot from the Medical College of Wisconsin. She is a surgical critical care and acute care surgery fellow. I'll be talking about one of the trauma cases that came in over the last couple of months, and Dr. Patricia Popowicz, also a critical care fellow as well. I apologize, Patricia, I don't recall off the top of my head where you're from.
Duke.
Thank you, Duke. We're also joined by an esteemed set of panelists, with Dr. Helena being one of those. Maybe Dr. Helena, I'll have you introduce yourself, and then we'll move on to the others.
Sure. My name is Dan Helena. I know a few of you on the call. I am the current section chief of acute care surgery at the Medical University of South Carolina. Really honored to be here today. Looking forward to the cases. I have the privilege of having met both of the presenters, which is exciting to me. So I'm looking forward to this and can't wait to hear what the other panels have to say.
Apologies, this is our other expert panelist, Dr. Hardcastle. I'm going to take this so I can get him connected. Dr. Rodas, do you mind?
Yes. Hi, everybody. I'm Edgar Rodas. I'm a trauma surgeon at VCU Health. I'm the current president of the the current secretary of the Pan American Trauma Society. And this is my first time being here, so I look forward to hearing from everybody and listening to the presenters.
All right, Dr. Calderon.
Yes, good morning. I'm Roberto Calderon. I'm from Lima, Peru. I'm a general and emergency surgeon. Thanks.
Very good.
I'll be moderating one of the cases.
Great. And I'm Dr. Chris Dodgen. I'm from the Medical College of Wisconsin, trauma and acute care surgeon. This is my first time actually joining this as a moderator, so I appreciate the opportunity to be involved. I'll be moderating also one of the cases. And then we have Dr. Tim Hardcastle is one of our other expert panelists. He'll be joining in just a few minutes. I think with the time change in the US, he's a professor of trauma and surgery in South Africa. I'll have him introduce himself once he joins. He's just going to join in a couple minutes, but given the time change in the US, I think he was expecting to join in about an hour, and will be joining now in just a few minutes. So maybe with, I think, most of our introductions completed, why don't we go ahead and plan on getting started? I don't know, Patricia or Margot, which of you would like to go first with your case?
I can go ahead and start us off if that's okay.
Sounds great.
All right. So today I'll be discussing a case of complex abdominal vascular trauma, case of a patient who had a gunshot wound to the abdomen. So I want to thank you all for the opportunity to present today. I'm excited to kind of hear everyone's insights in this case. So the patient presented as a trauma alert, which is our highest level of trauma activation. He had reportedly been in a motor vehicle collision and then sustained a substernal gunshot wound. On arrival, his airway was patent, his breath sounds were clear. He had a heart rate in the 90s, but weakly palpable peripheral pulses and a GCS of 13. And we were initially unable to obtain a non-invasive blood pressure. As we worked through his resuscitation, initially activated MTP because of our concern about hemodynamic instability. Did initially have some difficulty obtaining access, and then started our workup while we were obtaining access, first with a pericardial FAST and a chest x-ray, which were negative for any findings. Then he had a KUB with a retained micelle, and notably he was moving all extremities spontaneously. So
Maybe
here are, sorry, go ahead.
I was going to say, I was just going to say, maybe we'll pause for a second. And Dr. Helena, uh, does that seem reasonable? Is that what you would do where you are? You are on mute, so it's hard to tell what you would do.
It's hard to tell even if I'm not unmuted, honestly, Dr. Dodgen. Yeah, this is obviously a very challenging case in the sense that you have a combined mechanism of both blunt and penetrating trauma. I'm reassured to hear that the pericardial FAST was negative, but obviously looking at this trajectory it is concerning, as is the fact that you can't get access. I wonder, what did you guys try to get access?
Yeah, so we initially tried multiple peripheral IVs and did ultimately get a tibial IO, which ultimately, as we'll get to, was probably not the most ideal access for abdominal trauma, and in the future would start with something humeral. And then it did eventually get I believe a 20 gauge in his AC before we took him upstairs. We didn't attempt a central line, and I think just knowing, after seeing the trajectory, the goal was to get him upstairs and to kind of minimize time that we spent in the trauma bay.
Dr. Rodas, similarly, in terms of access challenges and what your go-to is in the trauma bay?
Yeah, I agree. I think we're very quick with the IO. We don't waste time, and I think that doing that to enable you to start your MTP and get to the OR as soon as possible is the best move.
Great. And it looks like, I believe, Dr. Hardcastle has also joined. Maybe I'll give him 1 second to get his video on and technology worked out. But we just are beginning the very first case that we're going to discuss. If you wouldn't mind introducing yourself, that would be great. This is a middle-aged male, gunshot wounds, and MVC. Is that right, Margot?
Correct, yeah.
Okay.
Combination case just showed up, unable to obtain a blood pressure. It did do a pericardial FAST. We were just talking about sort of initial workup and access challenges that they were having.
So the entry wound, that little paperclip, is that anterior or posterior?
So that's anterior, retained
Anterior.
missile and no other wounds.
Technically subxiffy. And what's his level of consciousness and everything else?
He's confused but vocalizing.
And saying his belly is sore.
Yeah, he wasn't complaining as much as he should have been, I think, but...
If this was in my scenario and the EFAST was negative for the chest, I would be going straight to the operating room. If that bullet is sitting anywhere in the abdomen, and again, I don't know what his body habitus is like, so he might be one of those that has lots of autologous body armor, but unless that's the case, I would probably be rushing straight to the operating room with him. And again, my apologies for joining late. The change in your daylight savings time had me down for 7 p.m., not 6 p.m. at my time, which is what it is now.
I appreciate you joining. Do you mind introducing yourself or letting folks know?
Okay. So I'm Tim Hardcastle. I have been on this meeting before. I'm the head of trauma and burns at the Inkosi Albert Luthuli Central Hospital in Durban, and I'm a full professor of surgery at the University of KwaZulu-Natal, which is also in Durban, South Africa, where we see a few bullet wounds every now and then.
Dr. Hardcastle, you mentioned an EFAST. In particular, what are you interested in terms of your FAST exam? Are you doing the complete FAST?
So the EFAST for us goes beyond just the abdomen. It includes a quick look at the two pleural spaces for pneumothoraces, which probably, if you look at the stats, it's more accurate for picking up pneumothoraces and hemothoraces than a chest X-ray at the moment. I'm not looking at the abdominal. I'm not looking at the abdominal views because it's penetrating trauma, and as far as I'm concerned, FAST for penetrating trauma is unreliable.
Now, this case does happen to be both a combined case, which makes it a little bit more interesting, of penetrating trauma followed by an MVC, so there is a blunt component. Does that change sort of how you'd the weight that you would give to the abdominal FAST?
Not really, because there's a bullet hole, and we don't know where the bullet is. And the treatment of penetrating trauma is more operation, less examination, and unlike blunt trauma, which is more examination and conservative management, there's an indication against conservative management. So for me, ushlinzwa ubsizu, as we say in Zulu, cutting the abdomen is what we have to do.
Got it. So I'm taking too long, is what you're saying. So with the too much faffing about the access issues, I would mention getting an IO, obviously below, especially with a potential sort of intra-abdominal trajectory. A lower extremity IO may not be the most ideal. Dr. Debot, you mentioned humeral IO. I also wondered about Dr. Rodas or Dr. Helena, how often you might use a sternal IO in a situation like this.
So I would probably not do the sternal IO. I think the humeral IO is a better option. And I think the one thing that I will add on, since it is a combined mechanism of injury and you don't want to be caught with something that you may miss, I think that adding just a pelvis film is maybe useful depending on the time you have. It's always good to know your cavitary triage and know what cavities you may have to engage to stop the bleeding.
Yeah, I would agree with that, except with the caveat that I think you can see the top of the pelvis pretty well here. So, you never know. He could, I guess, still have a pretty big open book. But if you have one hole and one bullet, and assuming he's not been shot before, then I think you have a pretty good understanding of what would be in play from at least the penetrating perspective.
And certainly, if you're considering at least the humeral IO, doing on the opposite side of the bullet entry may be sort of warranted. Somebody did mention in the chat about Reboa. How many of you guys are thinking of Reboa versus OR? Is that something you guys use regularly?
Very limited access in the public service in Africa. Even in the private services, it's limited.
Sounds good. All right, Dr. Debot. Thanks for waiting.
Yeah, so as many suggested, he was taken emergently to the OR for exploratory laparotomy. Notably, he did have a pelvis x-ray in the trauma bay, which I just didn't include in that initial slide. So we took him upstairs. He very quickly got a large bore central line placed and an A line by our anesthesiologist. We prepped and draped and then induced, and he did become unstable with induction. We immediately performed a midline laparotomy and noted a moderate amount of hemoperitoneum, packed all four quadrants. And on exploration, the missile had transected the caudate lobe, and there was both brisk bleeding from the caudate lobe as well as bile staining, and this was packed for hemostasis. And as we explored the abdomen, there really wasn't an explanation intraperitoneally for the degree of hemodynamics instability that he was exhibiting. However, he did have a zone 1 hematoma. And so we went ahead and explored the hematoma. We did a right medial visceral rotation and Coker maneuver, and as we Cokerized, the duodenum experienced what I would describe as torrential bleeding from his retroperitoneum. We initially controlled this with manual pressure and then vascular clamps, and then noted that there was about a 3 centimeter transection of the IVC, as well as what appeared to be a right renal artery injury at the superior aspect of the IVC transection. Of note, our dissection and hemostasis was complicated by his body habitus. He had a BMI of about 40, but was of 6'5", and so this was an incredibly deep area to be working in. And by the time that we had obtained vascular control, he'd received over 30 units of blood products. He was acidotic and hypothermic, with coagulopathic bleeding from the exposed retroperitoneum. However, sorry, go ahead.
I was just going to ask Dr. Hardcastle, Helena, and Rodas, what do you think? Going well at this point?
I think I'd be looking to quickly take out that right kidney and ligate the IVC. I've done 5 IVC ligations rather than try and fix it or pack it, and 4 of them survived.
I would agree with the nephrectomy. I think I would try to take a better look at the IVC injury to see if I can repair it.
Yeah, I think wow, tough case. You know, when we teach the ATOM course, one of the things that we sort of do is is you know, an IVC injury. Sometimes when I'm feeling feisty, I must admit that I will make the injury at the junction of the IVC and the right renal artery just to make it more complex to repair. I think the nephrectomy is 100% done. That said, if you do have control, like if you know, by now, I might be with Dr. Rodas. I'm not sure that I would necessarily ligate that, although I agree with you, Dr. Hardcastle, that that probably would be associated with survival.
Dr. Debot, what did you guys do?
Yeah, so we ultimately determined that we ligated the IVC. We felt that his best chance at survival was performing a damage control operation. We also discussed, you know, the fact that the the left kidney was present and presumably intact and would have some collateral damage or drainage from the gonadal vein, and so, you know, we were hoping we could preserve his kidney function. Now, interestingly, the renal artery injury was rather proximal, and we had control of it with vascular clamps, and so we elected to just ligate this as opposed to performing a nephrectomy, which, you know, I think sometimes it's better to be lucky than good as we go back through this case. So we ligated the IVC successfully in the renal artery, and then continued our exploration, found a pancreatic head contusion with some bile staining on the exposed duodenum, but there was no gross spillage of succus at this point.
Just a point of clarification, when you ligated the renal artery, were there sort of accessory arteries, or was the plan that you ligated the renal artery to help control hemorrhage and with the intent to come back and do a nephrectomy after you sort of address the other injuries?
Yeah, so the plan was to ligate the renal artery. It seemed like the most expedient course, and then to reevaluate when we came back. And ultimately, this did turn out to be an accessory artery, which we were not aware of at the time. And so, you know, I potentially, as we performed a nephrectomy, we would have better delineated the renal vascular anatomy and may have, you know, kind of changed our plan at that point. But, you know, turned out that fortunate for him, because he ultimately was able to spare that kidney. And, you know, we had discussed this bile staining on the duodenum as certainly the trajectory was concerning for duodenal injury, but with his physiologic state at this point and the lack of kind of gross contamination, we just elected to terminate the procedure at this point and transferred him to the ICU for further resuscitation.
Similarly, Dr. Alina Rodas and Hardcastle, reasonable decision? Would you have persisted a bit longer?
30 units of blood products, get the hell out of there.
I agree. You can, if there's no gross contamination, you can pack and then recover the patient and come back.
Yeah, I mean, if you're going to be coming back in 48 hours anyway to unpack the liver, you know, if he stabilizes, you're going to be looking at everything again.
Yeah, I'm curious to know where this bile is coming from, but I expect you're going to tell us in the next slide or two, so stay tuned.
Yeah, so ultimately his intraoperative transfusions, he required 28 units of RBCs, 28 units of plasma, 7 of platelets, and 4 of cryo, and arrived to the ICU with a lactate of 5.8. He received just 4 additional units of product overnight, but stabilized in the ICU, was not on any pressors, and due to his combined blunt mechanism and also suspected spinal cord injury, we ordered postoperative CT scans. And
just to clarify, the platelets are 7 units of platelets or 7 bags of platelets?
7 bags of platelets, so I guess it'd be 70 units of platelets.
Usually it's
Uh,
6 per. Okay. Sounds good.
Yeah, a little higher on the platelets, and to be honest, I didn't review his
Just
intraoperative
for
test.
those of us who are not in the United States, what is your standard platelet mix? Ours is what we call a 5-pack. So is yours higher than?
Our MTP coolers arrive with 7 of our blood cells, 7 of FFP, and then 1 of platelets. Presumably from a. Sorry, my slides are advancing on their own. Presumably with 7, about 7 pooled platelets in a plasma for
So yours is a
bag.
7 pool. Okay, yeah. So
Yeah.
ours is a 5 pool. Okay, thanks.
Sorry, so we got our postoperative CT scans, and really most notable for what looked like adequate perfusion to both kidneys as well as drainage from the right kidney. He did have some dilation of the renal vein on the left. However, we had packed the retroperitoneum for coagulopathic bleeding, and so it was a little bit unclear what his vasculature was at the time of our CT scans. It also showed an L3 vertebral body fracture, grade 3 liver injury, and pancreatic head injury. And as he had been adequately resuscitated on hospital day 1, we took him back to the operating room for a second look and found a through-and-through injury of the D1 portion of the duodenum, which was repaired primarily. We opened the anterior injury, repaired the posterior, and then repaired the anterior, both in a running fashion. However, there appeared to be ongoing bile staining in the retroperitoneum. And so we discussed kind of how to further evaluate for injuries at this point.
Just to pause for 1 second. Would everybody in your setting get a postoperative CT scan these days?
Yeah, we do it standard.
I think especially based on the potential for the blunt mechanism would probably be reasonable. From the penetrating mechanism, though, I don't know. I mean, it seems like you have a pretty good understanding of the trajectory, so I'm not sure it's necessary for that reason, but I think if there's concern for other injuries, then maybe.
Yeah, I mean, we would have got a CT scan depending on what the GCS is, the head C-spine, and possibly a vascular run, but not really scanned the abdomen because we've been there 20/20 vision.
The only thing you would have missed was the spine injuries, no? So I think that's important. Just scanning,
Yeah.
you don't lose anything.
But as a general rule, penetrating spine injuries are stable injuries if you look at the literature. So, yeah.
Thanks.
Yeah, I think that's a really interesting point because the rationale had been both we wanted to scan his head and his C-spine for the blunt mechanism, but then concern for this penetrating spine injury, which he did in fact have, and ultimately did not require any sort of interventions, as Dr. Harkessel mentioned. So, so in the operating room, with kind of concern for ongoing injury, we actually performed a transcystic cholangiogram, which looks like it was positive for a intraparenchymal common bile duct injury. And so in conjunction with our surgical oncologist, we took him to the OR the next day for a pancreaticoduodenectomy. And what that was interesting is postoperatively, the surgical oncologists who I think are less familiar with IVC ligations in their patients, not that that's incredibly common, were pretty concerned and discussed whether or not it would be worth reconstructing his IVC now that he had stabilized.
What do you guys think? Anybody reconstruct the IVC after ligation in trauma patient?
I think that's a bad idea because now you're going to have the risk of leakage of, like, assuming, maybe your pancreaticoduodenectomy goes great, but if you leak and now you have a cable anastomosis or something, I don't like that at all. And I'm not, my assumption is that you would do that with some sort of prosthetic graft, and I don't know. I don't like that idea.
Yeah, what I've done in one case is we didn't ligate the IVC. We narrowed it 70%, and then later on came back and place a stent and subsequent dilation months later with no reconstruction.
Yeah, I was going to make that suggestion myself. We would probably, through the transcystic cholangiogram, put a guide wire down, and if it came out in the duodenum, we would probably thread a plastic tube stent over it and leave drains, suction drains. That's basically because we wouldn't have the access to pancreaticoduodenectomy very easily. Our surgical oncologists are very conservative in South Africa.
How does that typically go, Dr. Hardcastle, in terms of what's the success rate of? Sure, you guys see these all the time, right? So
no, I've seen 3 in my practicing lifetime. One was just at the entry to the pancreas, and what I did with that is put a T-tube and a Braun loop up, and it healed without a problem. The other 2, we did guide wires and then popped a stent through and allowed it to granulate up, and luckily they actually healed up. But it took a while.
any other kind of pearls or points? I realize we are getting close to time for the finishing of the first case.
Well, the other thing you could have done here to avoid a pancreaticoduodenectomy is actually just divide the duct where it comes out of the liver at the junction of the common duct, and do a T-tube hepatico-jejunostomy using a Braun loop, which is, as I say, that's what we've done once before when I worked at Tygerberg, and that worked quite nicely. And the Braun loop reduces the risk that you'd have of multiple Roux-en-Y type anastomoses.
And then, so that provides obviously sort of proximal diversion of the bile, sort of protects that sort of injured area. Is that also in conjunction with the stent?
No. That's just that's the other option. Is identify and divide the duct above the pancreas, and pop it into a Braun loop over a T-tube, and as definitive management. Then you don't have to worry about now doing a massive pancreatic resection, because you've now defunctioned it, so it's not going to drain any bile. You haven't shown that the pancreatic duct is injured, so why take out a good functional pancreas?
Do you further evaluate the pancreatic duct before sort of deciding, or sort of intraoperatively?
Well, you should, during your cholangiogram through the gallbladder, be able to see retrospectively if if there's retrograde filling of the duct. Normally does.
Dr. Alina, Dr. Rodas, thoughts?
Yeah, can you show us, Dr. Debot, can you show us that cholangiogram again?
Yeah. I think because of kind of the brisk injury that we saw, I don't really see it refluxing into the pancreatic duct, unfortunately.
Yeah, I would be concerned that actually does involve the pancreatic duct.
Yeah, I would be a little bit worried about that too. And I guess that would be the counter argument to that, is that you're still going to have a main, pancreatic duct in the head injury, which you could. I think Dr. Hardcastle's correct in that. I think you could probably still manage through that, but I would think that would require some kind of a stent or something to get the ambula open.
And Dr. Debot, any? I can't recall exactly when this case came through. Do we have a general follow-up on how the patient's doing?
Yeah, so we did get a renal Doppler ultrasound, which showed patent bilateral renal veins, which was kind of sufficient. Everyone agreed that reconstructing the IVC, for all the reasons we've discussed, would not be prudent. And then his course was further complicated by fascial dehiscence and intra-abdominal abscess, potentially due to that delay in our initial management of his duodenal injury. However, he overall did reasonably well, had a chyle leak, which was also managed conservatively, insulin-dependent diabetes, and then a right femoral nerve palsy, possibly from his iliopsoas hematoma. And then he did have some frostbite. He had, in between the car crash and gunshot wound, been kind of in a chase through the forest and a little bit unclear, but required some debridement for that. But ultimately discharged to acute rehab on the hospital day 34, which was just a couple of days ago, ambulating, tolerating a regular diet. And so, overall, I think with his injuries, a pretty positive outcome.
Dave.
Great. Well, thank you very much for the presentation. Nice job. And I think with time, we will move on to our next case.
Thank you, guys.
Yeah.
You wanna
Hello,
see my-
Dr. Popowicz. Yes, we
Hello?
can see your slides.
Perfect. All
Okay,
right.
yes, please, can you start presenting your case, please? You're from Duke. Did you say you're from Duke?
Yes.
Okay,
Okay.
nice to know you.
Nice to meet everybody. So my name is Patricia Popowicz, and today I'll be discussing a case of inhalation injury in the difficult airway. And I am from Duke. I have no disclosures. Some learning objectives are going to be to describe the presentation and diagnosis, initial management of inhalation injury, as well as recognizing and managing a difficult airway. So per our EMS report, she was described to be a 25-year-old female who was found asleep when she was extricated from a structure fire. She reports that she was in the home for about 5 minutes, but details are unclear. She had significant amount of soot on the face, nares, and layered on her tongue. She did have a raspy voice and copious amounts of black secretions noted, and she refused to be suctioned. Her lungs were clear bilaterally, and her blood pressure is in the 140s, 150s, heart rate 120s, 140s, respiratory rate of 15 to 18. Initially, her SpO2 was 81%, but subsequently improved to 95% on 15 liters non-rebreather, and she was noted to be a GCS of 14 at the time. Apart from the non-rebreather, he placed a 18-gauge right AC peripheral. So the next question is ultimately, where does this patient go? From the scene of the incident, it was 15 minutes to our hospital, but it was 31 minutes to a certified burn center. Based off of the patient's clinical presentation and EMS capabilities, they were not able to perform RSI en route if something happened. And due to that reason, she did appropriately come to our center.
Can we ask Dr. Rodas, please? Dr. Rodas, can you ask this question for Dr. Popowicz? What do you think?
Yeah, so I would be very worried about this patient. I think anytime we talk about inhalation injury, you don't want to underestimate these injuries and the potential for catastrophic airway loss. I think that you have somebody with a good mechanism and presents with positive signs and symptoms and clear respiratory distress, carbonaceous sputum, changes in her voice. I assume she may have some difficulty swallowing and requiring quite a bit of support. So I would err on getting a definitive airway on her as soon as possible.
Thank you, Dr. Rodas. Dr. Hardcastle, what about you? What do you think about this question?
I think, and we certainly teach our services that if they are not able to secure the airway with intubation, and we have paramedics who've got a 4-year degree that can use RSI drugs, etc., and can do that. But if there aren't such paramedics on scene or in the vehicle, they go to the nearest emergency department that has facilities to provide the RSI. And once you've got a secure airway, you move the patient where they need to be. So yeah, I absolutely agree that if there's an appropriate trauma center close by, even if they're not a burn center, patient goes there, gets airway sorted out. They can also check and see if there's any need for escharotomies, etc., to prevent further ischemia before transferring onward.
Good. Thank you, Dr. Hardcastle. Dr. Holina, let's skip that question and let's say the patient is already coming to your hospital. How do you set up for this situation?
Yeah, great question. So obviously this is really concerning when you get this in pre-hospital report. I think you would probably want your best airway team available. I think in this situation, we usually just have emergency medicine in the bay. I think for this patient, maybe getting anesthesia down, getting a bronchoscope and a fiber optic intubation setup, certainly having a surgical airway kit. I don't always open those before the patient arrives, but this might be one where you might actually consider that. And then I think probably the most important thing here is before the patient arrives to basically just take a pause and talk through what is going to be our airway plan. Like, we're going to do this many, we're going to try this technique. We're going to do it this many times. And then we are going to, if that fails, we're going to quickly, flip into our surgical airway. Just so that it turns into, everybody knows what the playbook is going to be before the patient arrives and you're not stuck there with all these resources with a very sick patient, but no plan.
Okay. So when she did arrive to our emergency department, she was able to speak full sentences. She had expiratory bronchitis to
Okay,
auscultation.
thank you for the answer, doctors. So, Dr. Patricia, keep going. What happened actually with the patient?
Yes. Okay. I'm sorry. I guess I jumped ahead. So she had expiratory bronchitis to auscultation. We did note the soot on the face and tongue and carbonation sputum. She is morbidly obese. Her BMI is 54 with a short neck. Of note, she did have a laparoscopic sleeve gastrectomy done 2 years prior when she had a BMI of over 70. Her heart rate is in the 110s to 120s, blood pressure in the 130s, and she was satting 95% on non-rebreather. She was noted to have a GCS of 15 at the time and speaking in coherent sentences, and she had no signs of cutaneous burns. So with this, during her examination, we did get some quick labs. So her white count was 11, hemoglobin was 13. We did not have an A-lines yet. So VBG showed the gas of 7.38, 45, 32, and 27. Her carbon monoxide levels were quite significantly elevated at 31.9, and she's on 100% non-rebreather, and she does have an elevated lactate of 3.6. Here is her chest x-ray that was done in the trauma bay, and apart from some bilateral patchy opacities and maybe some pulmonary edema, it was ultimately unremarkable. And shortly after, she did start to develop stridor. So one of the questions that I had for everyone is, how would you approach this airway? And I know we started talking about it briefly already.
Like what Dr. Helena said,
we have a very obese patient. Hello, Dr. Hardcastle?
Yes, we can hear you.
Oh, yes.
Your signal breaks
yes,
up
how
and
would you approach
comes
this
and
patient?
goes.
We have this obese patient with inhalation injury who's having.
Yeah, I mean, we would definitely set up for a definitive airway. We would be looking at, as a minimum, probably a video laryngoscope with a bougie, and we would be looking at ketamine, rocuronium as our preferred induction agents, which is what we use generally for trauma. We've completely moved away from succinylcholine in trauma patients, not only burns patients, but across the board. And we would have the bronchoscope ready as well if we need to do if she's not cooperating. And again, liberal lignocaine spray, and possibly a heparin NAC neb or a heparin alone neb prior to starting while that's the only thing that level 1 evidence supports as a preparatory task at the moment. And yeah, then we would do a controlled intubation, and I agree with Dr. Helena. We would certainly have the surgical airway kit available, although having said that, She doesn't have cutaneous burns, but if there's cutaneous burns, doing a surgical airway through burnt tissue is never a good idea.
Thank you, Dr. Castro. Dr. Holina, what's your opinion about this situation? What would you do?
Yeah, I mean, it sounds like she is going to need to be intubated and sooner rather than later. I think, having outlined the steps for preparation, I think the next thing is, I agree with the ketamine. I am a little bit worried that we're going to convert her into something like right now, we might be able to ventilate her even if we can't get a tube in. But if we paralyze her, we're not going to be able to do that. But that said, with her body habitus, I'm not real confident that we're going to be able to mask ventilate her, even if we're having difficulty with the airway. So I think this is one of those ones where you just push both the meds. You know you're going to paralyze her, and you may not be able to intubate, but you're so ready to do the airway that you just quickly transition into that.
It looks like Dr. Calderon is frozen. Dr. Rodas, any different things to the order of events there?
Okay, thank you, Dr. Holina. And Dr. Rodas.
Yes, so I agree what's been said. I think I will second what Dr. Helena was saying at the beginning, that this is a patient that you want to make sure that everybody's roles are assigned before. I think certainly before the stridor set in, we have a policy here in our ED for difficult airways that the ED resident gets one and only one attempt, then the ED attending gets the second attempt. And we are fortunate to have our anesthesia providers there, and they do the third. And if they cannot, we will do a surgical airway. I think in this case with the stridor, I would move straight to our anesthesia providers, which would be the ones with the most experience, to have all the toys available as mentioned and ready to go with us, almost with our hands on the equipment ready in case we need it.
Thank you. Can you hear me well now?
We're back in, sometimes on, sometimes you freeze, Roberto. I don't know if you want to try to connect via a different way, or maybe we can let Dr. Popowicz continue from here.
Yes, please. Can you take over, please? Thank you.
Go ahead, Dr. Popowicz.
So that is kind of exactly what we did. We had the most experienced provider in the room proceed with intubation. We were pre-oxygenating her. RSI was performed with the Tomate and Rock. We have a difficult airway kit that is in all of our trauma bays that has various sizes of endotracheal tubes, bougies, LMAs, OPAs, NPAs, DLs, NLs, fiber optics. And ultimately, despite with all of our attempts, we were unable to successfully intubate her ×2. She had a very interior airway. She had micrognathia, upper airway edema, which is to be expected in her situation, and Mallampati 3 and 4. And during this time, ultimately, her SpO2 did drop to 50%, and we were all ready to perform a surgical airway during this time, and that's what we ended up doing. So we emergently criked her using a 6-cell endotracheal tube. We positioned her as quick as we could and made a generous 5-centimeter incision above where we believe the cricothyroid member would be. And once we were able to get into position, we placed the bougie and placed a 6-cell endotracheal tube and confirmed placement with a bedside bronch in addition to end-tidal CO2. And kind of given how difficult this airway was, in addition to her habitus and everything, we just wanted to make sure that we had a very secure airway, and ultimately immediately brought her upstairs to our operating room where we would be able to better evaluate her airway and get something a little bit more stable instead of a 6-cell endotracheal tube.
Any thoughts on that? Was your incision transverse or longitudinal, vertical on the skin?
It was vertical.
Just vertical.
Mhm.
Dr. Hardcastle, Helena, and Rodas, any other way you would have done this in the trauma bay before going up to the operating room? Would you have gone up to the operating room?
I
Thoughts there?
I gotta say that you know, understanding that better is the enemy of good enough. If you know, or if you think that you're going to be doing a surgical airway, I think a pretty nice move is to basically have a tracheostomy appliance ready to go. For her, maybe you don't have the right one that fits, but it sounds like she would definitely at least be a proximal XLT. But sometimes when you're doing this, you can load that up over a bougie or an NG tube, and then just put it in there. And then, once that's in place, you can confirm the position with a bronch. And at that point, you kind of have a much more stable airway than you do if you have this long endotracheal tube hanging out of somebody's neck. So I think in the right clinical situation, if you have the time to prepare, that might be something that you can do that then does not necessarily obviate doing something else. Because I don't think anybody likes seeing that giant endotracheal tube hanging out of somebody's neck. But just food for thought.
Yeah, I might have done the only thing I would have done differently. So, just a question to Patricia: did you use a bougie to place your trachea tube, or did you just do it blind?
Oh, yes, excuse me, bougie for and a 6-0 endotracheal tube.
Okay, so I mean, you know you're in with the bougie. You've positioned it reasonably. You can cut the tube short so that you reduce the dead space that Dr. Helena is worried about. So I would have probably at that point done the bronchoscopy bedside and kept her on a sort of a ketamine infusion or something for both analgesia and sedation. We always routinely do a bronchoscopy on any intubated inhalational injury so that we can classify according to the 4 grades the extent of the inhalational component, which is separate from the external smoke effects or edema effects. And the chest X-ray suggested that there was probably already some pulmonary alveolar component.
I agree. I wouldn't have done anything different than what's stated. I think the vertical incision is the one almost everybody would have chosen to do this. So yeah.
Okay. So we did bring her to the operating room, and we wanted to see if we would be able to intubate from above to have a better visualization of where our endotracheal tube is, with the hopes of exchanging it over for a larger and more secure airway to kind of promote further pulmonary hygiene and having something more secure. But this is a video from our anesthesiologist. You can see how severely edematous her upper airway is, and we were unable to pass a bougie despite a few attempts, and we ultimately elected to not proceed with taking a look from above. And next is our bronchoscopy that we did, and you could see how much of a severe inhalation injury she has. She has a grade 4, and kind of just confirming everything that we already suspected. So
Dr.
with that,
Popowicz, yeah, your intubation from above, what was the sort of reasoning? You had the secured airway through the cricothyroidotomy?
yes. Ultimately, we wanted to kind of have the exchange this for an 8-0 endotracheal tube, an armored one, just to have for having a better airway that's a little bit more rigid, and so we could do better palm hygiene. And one of the thoughts of just looking from above is just making sure we could do this under direct visualization, but ultimately that was not able to be obtained. And given the fact we have a more controlled setting as well, another reason for us to kind of we just wanted to have a better look as well.
Got it. So thinking you need a larger size ET tube to facilitate ongoing bronchoscopies given sort of the inhalational injury, etc. What do folks think about that? Or I guess another add-on question to that is, at what stage would all of you, Dr. Lena, Rodas, and Hardcastle, consider sort of converting this to your standard tracheostomy?
I would do it early, but again, depends on the size of the patient and so on. But yeah, our rule is if you've done a surgical crack and you've cleared the issue, you convert that within 24 hours to a tracheostomy.
Would anybody just leave a little bit of what Dr. Helena said, a tracheal tube through the cricothyroidotomy? So a tracheostomy appliance, be it a Shiley or a Bariplex or any of those, but at the cricothyroidotomy incision instead of creating an additional airway hole, and then to secure it a little bit better than the elaborate chest tube like securing that you did there, which sometimes can still be treacherous and come out.
I'll jump on that, Dr. Pasquale. Yeah, I think even for someone with a deep neck like this, there's something called an adjustable flange tracheostomy, which is very similar to what you see here. It's an armored endotracheal tube that goes through a tracheostomy appliance and then can be secured at the depth that you choose to place it at based on bronchoscopic guidance. So I think that's a great option for a patient like this. I would, I'm going to go up for this patient, maybe they will require a long-term tracheostomy because they have a severe inhalational injury. But I would say that I do not believe that the evidence supports that cricothyroidotomy needs to be revised to a tracheostomy for most patients. So I do not do that routinely. But, everything is contextual. And if this patient is going to have an airway for, weeks to months, then maybe, but not usually.
We have some comments there from Luis Traveras, as well as from Brazil. Francisco Colette is asking, who did the early bronchoscopy? Did we do a bronchoscopy, Dr. Popowicz?
Yes. So down in the emergency department, we just did a quick bronchoscopy to confirm placement. In the operating room, our anesthesiologists, along with the surgical team, we both did the bronchoscopy.
Okay. And then do you want to keep going, Dr. Popowicz?
Yes. So when we were looking at where our tube was, it actually ended up being in the second tracheal ring instead of the cricothyroid membrane. We ultimately placed the 0 Prolene stay sutures over a bougie, exchanges to the 8-0 armored tube, which you see here. And this is how it was secured. And she was brought to our surgical ICU for further resuscitation and management while we were in contact with our burn center about transferring. In the ICU, her initial labs show that she was pretty acidotic. She has a component of respiratory and metabolic acidosis with P to F ratio of 121. She had a pretty significant base deficit despite resuscitation efforts, and given all of that is taken into context, and also that she was slowly becoming hemodynamically unstable, we elected to give her cyanide. We also provided started the pharmacological treatment for inhalation injury with albuterol and acetylcysteine and nebulized heparin alternating every 4 hours. For her, it was 7 days or until extubated. We elicited also lung protective strategies and continued the 100% FiO2 for a total of 6 hours until her carbon monoxide level was less than 10, which we were able to achieve. However, while she was up in the ICU, she did become more unstable and her labs were worsening to 7.01, 47, and P to F ratio continued to drop. Given the fact we have a very fresh airway, we were unable to prone her safely. We did optimize her sedation. We reparalyzed her and made appropriate vent changes as well, but we were just not making any headway and she was just declining. Started inhaled nitric oxide as well to temporarily improve oxygenation and while continue resuscitation. Kind of given the fact that we were concerned of her continued decline, we elected to consult our ECMO team earlier. And they ultimately cannulated her through both groins and for VV ECMO. And she also had a right chest tube that was placed for pneumothorax.
Dr. Popowicz, can you tell us what a cyano-kit for those of us that may not be familiar with that technical term?
Yeah. So cyanokit is hydroxycobalamin. It is typically in this indication used for cyanide toxicity. However, a cyanide lab is a send out and could take quite a few days for it to actually come back. So when you have patients within the right context, meaning if they're in an enclosed fire where you have presumably plastic or mattresses, couches that may be up in flames, you have hemodynamic instability despite resuscitation. You could have a lactate of greater 8 to 10, depending on what institution you're at. Or you have elevated carbon monoxide levels and you're just not making headway. These are the patients that we would typically, or one would typically give cyanokit for. However, sometimes, especially if you do work at a burn center, it may be given pre-hospital, even if the mechanism wasn't appropriate, just due to availability and other reasons.
Dr. Helena and Dr. Rodas, Dr. Hardcastle, would you have diverted towards ECMO as well? Would you have proned this patient? Given anything else?
As I put in the chat, we don't have access to nitric oxide or ECMO in most South African centers, so we would probably have persisted with an alternative mode of ventilation. We would have probably gone to PRVC and tried that, because generally we would be using standard SIMV with pressure support. And obviously, if that didn't work, we may have to fully paralyze and go for CMV, but that's kind of where our armamentarium ends. And the same goes for most African countries, unfortunately.
I think we would have tried the more non-conventional modes of ventilation if we could, and then sure, ECMO is a great tool.
I'm with Dr. Popowicz. I don't like the idea of proning this patient with the fresh surgical airway. So I think, if it were available, I would go to ECMO early.
All right, take us to the end, Dr. Popowicz.
Okay. Well, this is her chest X-ray after getting cannulated. As you can tell, it is worse. We have the right chest tube that is also in place, and you can see the very low lung volumes and the opacities on the right as well. So because of how our center works, VV ECMO is typically being either managed in the CT ICU or the MICU. So she did end up getting transferred to the CT ICU. She got further resuscitation, and ultimately her lab values were improving, as well as her lactic acidosis. The following day, while we're making some headway, we were also waiting for our trauma scans, given the fact that we don't really have a good story in terms of what happened beforehand. She was found to be moving all extremities and following all commands. However, about mid to late afternoon, she was no longer moving her right upper extremity. Her GCS at that time was an 8T, and we did obtain a stat CT head, which showed the large multifocal cortical and subcortical hypoattenuations concerning for infarcts involving the supratentorial and infratentorial brain, as well as the left medial thalamus, and pretty diffuse cerebral edema. Neurology was consulted, and given their concern for impending herniation, they recommended a neurosurgery consult. They saw the patient and said just continue having the patient within the typical sodium goal of 145, 150 and above, and a repeat CT head, and no indication for an EVD or craniotomy at this time. And her embolic stroke workup was started. Her ultrasound was negative. And here is also just the CT of the chest, which shows the bilateral opacities in addition to some pulmonary edema. And we also did serial bronchoscopies for the first few days just to make sure that she was having good pulmonary hygiene. And ultimately, after day 3, it was as needed for any additional therapeutic benefit. But with the second day, her embolic workup kind of continued. She did have worsening neuroexam where her GCS was then about a 5T, and the CTA of the head and neck that we obtained had worsening cerebral edema and obstructive hydrocephalus in the fourth ventricle. And given this, our neurosurgical team placed a right EVD and a decompressive suboccipital craniotomy. In the operating room, the patient was in the sitting position, and we had multiple team members there from all different teams to make sure that her ECMO cannulas were unaffected, and as well as her surgical airway.
I have a couple of questions, if you don't mind. So one is, what was the opening pressure on the ventric, and was there a reason why they didn't want to put that earlier on the patient with that exam? Perhaps it would have helped them do their intervention a little bit earlier. And then
Yeah.
the second question is regarding heparinization on your VV ECMO.
Yes.
Do you do it?
From the heparinization of VV ECMO, we just did sub-Q heparin, given the fact we did find the ischemic infarcts. And in terms of why they did not do it earlier, they said that she had a reassuring exam at that time. And neurosurgery saw them early at night, kind of going into the early phases of the morning. And so at that time, they didn't deem that it was appropriate. And in terms of her opening pressures, they were on the higher side, at least in the high 20s, low 30s, but I can't recall the number off the top of my head.
All right. Do you want
Just to confirm, was it a decompressive craniotomy or a craniectomy? Did they remove bone?
It was described as a craniotomy.
I think it might have been a craniectomy.
Yeah.
That's what I'm wondering, because that doesn't make sense. There's nothing to drain, so why do a craniotomy if an EVD would drain adequately? It must be a craniectomy.
All right. We're already at 104. Why don't you take us to the finish line, Dr. Popowicz?
Okay. So ultimately, her course waxed and waned. Her right EVD ended up having clots, and they were unable to free it up despite the interval increase in the IVH. So she had a brand new left EVD place. Her neuroexam continued to wax and wane. She had azotemia with an elevated BUN, and to take that off the table, CRT was also started. However, as the day progressed, in the middle of the night, her ICPs were over 68 despite maximal therapy, which included hypertonic saline boluses, maximizing her sedation, putting her into neuromuscular blockade, and ultimately a pentabarb coma, making vent changes. The EVDs were also troubleshooted, and ultimately her exam showed that she had fixed and dilated pupils. And as for EVDs were deemed functional, conversations were had with the family that this is a devastating neurological event with a poor prognosis. The family wanted to make her comfort care, and as she was an organ donor, they just wanted to honor her wishes, and she ended up donating some of her organs a few days later.
Thank you. A tough case. Maybe last word, any ideas that we can go home with, Dr. Hardcastle?
I just have a bit of a question. Do you think this was a complication of the ECMO tubing and with a clot, or do you think that this is secondary to the hypoxic episodes, either at the time of the fire or, and eventually showing up? What do you postulate as the underlying cause here?
it's very hard to really pinpoint one thing or another, given the fact that her embolic workup was negative. So that is still a possibility. However, given her degree of inhalational injury, she likely had severe inflammation with disruption of the blood-brain barrier, and all of this kind of put together, I think, just kind of precipitated the cerebral edema and ultimately progressing. But I can't pinpoint one thing causing to explain all of this.
You're muted, Dr. Pascal.
Sorry, the natural history of carbon monoxide poisoning in the brain, though, is multiple ischemic infarcts. So I would have put I think you said carbon monoxide was 30, 31
Yes.
on arrival. So anything above 25 can cause severe ischemic infarcts. Dr. Rodas, any final thoughts?
No, I think great case illustrating how you properly rescue a patient. Also a very tough case for the outcome, but you guys were prepared to handle everything. So thank you. Very nice case.
Thank you, Dr. Helena.
No, I would agree. You nailed the airway, and the rest of it is, just unfortunate things, and complications happen to complicated patients, and this is certainly one.
Well, very good. Thank you very much, panelists. Thank you, Dr. Popowicz, Dr. Debot, Dr. Dodgen, for a great session, and hope to see you next month. Thank you very much for joining all.
Thank you, everybody.